Hey, well, time to have a good time with cardiovascular physical findings, Conrad Fisher. Listen to the sound. All right, what is it? ¿Qué es eso, huh? Well, it's a young man who comes to the office, got a routine screen. Well, what does that mean? Chlamydia? You know, it's just, so the point is, what heart sounds, besides S1 and S2, can be heard in basically a healthy young man? And there's not that many things, because S4 is not a normal anatomic variant. S4 is hypertension, hypertrophic cardiomyopathy. And a murmur, not too much, but did you know that you can hear an S3? An S3? That was what that was. That was an S3 gallop. An S3 gallop can be a normal anatomic variant in a young, healthy person. It's the sign of rapid ventricular filling. It's an extra heart sound, that X, okay? It's most likely an S3 gallop, and the effect of inspiration on right-sided lesions. Now, by the way, okay, we're not saying that the sound is a right-sided lesion, but in general, right-sided lesions increase when you inhale. The effect of exhalation is left-sided lesions increase when you exhale. Right increase when you inhale, left increase when you exhale. And the significance of an S3 gallop in a healthy young man is nothing. That's the point. It's a normal variant. And step one and USMLE and our boards are very interested in having us protect our patients from too much testing. So what you're not supposed to do is order stress tests and echocardiograms on the person. You're supposed to know that an S1 and S2, the only other things you can hear in a normal heart sounds is to hear an S3 gallop in young healthy people, particularly athletic ones. Right-sided lesions increase in intensity when you inhale because inhalation increases venous return to the right side of the heart, and exhalation increases venous return to the left side of the heart. And that's why you can have a little splitting when you inhale, because when you inhale, you're increasing venous return to the right side of the heart. Here's that S3, lub-dub, very scientific, don't you think? There it is. It's a sign of, what is the mechanism? The mitral valve opens. The mitral valve opens, and then there's rapid ventricular filling. That's the step one question. What is the mechanism of that S3? Rapid ventricular filling. What is the mechanism of that physical finding? What is the mechanism of that physical finding? Rapid ventricular filling on mitral valve opening. And this is when you increase venous return to the right side of the heart. When you inhale, exhalation increases it to the left side of the heart as you squeeze the lungs. And S3 is normal in young people. It goes away. And if it comes back, it's worse. Now, an S4 is atrial systole into a stiff, non-compliant ventricle. S4 is atrial systole into a stiff, non-compliant ventricle that should normally relax and not change pressure. But when you have left ventricular hypertrophy, S4. S3, mitral valve opens and you have rapid ventricular filling. Oh yes. Our next one, orthostatic hypotension. Orthostatic hypotension. Orthostasis means it's a change in position. It's defined as a drop in blood pressure, 20 points of systolic, 10 of diastolic, 20 points of systolic. And what does orthostatic means? It means your volume depleted. But you have normal blood pressure when lying flat. You have a normal blood pressure lying flat like a hospital bed. And it's a drop in blood pressure when you stand up, and it's meant to detect subtle blood losses, 10, 15, 20%. The next best in the step in the management of anybody who's hypotensive is always fluids. What fluids? What fluids? First, second year medical students are always terrible about which fluids to use. Terrible, so I'll give you the idiot's version. When you don't know what to say normal saline. Yeah, normal saline brings up the blood pressure. Fluids, man. So Basically, it's the difference in the pulse and the blood pressure, orthostatic, when you go from lying flat to standing up. Now, your blood pressure should go down a little when you stand up, but it shouldn't go down 20 of systolic or 10 of diastolic. Are you crazy? Shouldn't go down that much. Okay, but when you have a person who's got a blood volume loss or dehydrated or GI bleeding, that's the most important thing. Lying flat, the blood pressure and pulse were normal, you sat him up and all of a sudden you're like, yo, dude, got a hypotensive. And that's what orthostatic is. It's a subtle drop in blood pressure that's not detectable when lying flat. Now, it's defined as a systolic drop greater than 20 millimeters or a diastolic drop greater than 10 millimeters. It's a 20-point drop in systolic or a 10-point drop in diastolic, or a greater than 10 millimeter drop in diastolic pressure. So the pulse goes up or the blood pressure drops. The pulse stays abnormally up or the blood pressure drops. That's what orthostatic means. It means a 15 or 20% volume loss. How much volume loss is a blood donation? A blood donation is only a loss of about 10% of bodily volume. That's a blood donation, only about 10% of bodily volume. So when you go standing up, you shouldn't drop your blood pressure or raise your pulse. But when you've lost 15 or 20%, you have a normal blood pressure and pulse when lying flat, but when you stand up, the systolic drops by more than 20, the pulse goes up by 10, the diastolic drops too. That's orthostatic. It's a wonderful thing. You're going to really know what you're talking about when you get onto the floors and you're walking around. It's really going to make you look smarter if you know what this is. That's why this card set, all of them, the physical findings cards and the farm cards, the diagnostic test cards, remember the ones that are in the bookstores is more just the step 2 and 3 version, and the ones here has everything the cards in the stores have, but adds enormous amounts for step 1. So when resting pulse and blood pressure are abnormal, well, you got to lose like 30% volume for a resting pulse just lying flat. You got to lose like 30% volume for a resting pulse or blood pressure to be abnormal. But orthostatic is less than half of that, 15%. And that's why it's an important finding. Because if you're waiting for the resting blood pressure or resting pulse to be abnormal, you're going to wait for a colossal blood loss. It's way too much. You give fluids. Orthostasis is to detect a modest amount of blood loss or fluid loss or dehydration where you're normal at rest, but when you change position, your carotids, cranial nerve 9, or your aortic arch, cranial nerve 10, cranial nerve 9, cranial nerve 10, glossopharyngeal, vagus, carried up to the medulla, the carotid signals, okay? The carotid will sense blood pressure, too high blood pressure, too low blood pressure. When the blood pressure is high, do you have increased stimulation or decreased stimulation when the blood pressure is high? When the carotid sense it for high blood pressure, is it increased signals or decreased signals? It's increased signals because these are stretch receptors. They are mechanoreceptors and they're stretch receptors in the carotid. So the signals in cranial nerve 9 go up. Low blood pressure, they're stretch receptors, mechanoreceptors. And the cranial nerve 9 senses less stretch, so the signal goes down. More signal for stretch receptors, less signal for those stretch receptors. They're mechanoreceptors, and basically they measure the pressure and the rate of that change as well. When you and I change position, there is a small change in pulse and blood pressure that should correct itself within 30 to 60 seconds. So if you have a person who has a very fast change in pulse and blood pressure, it will be detected and responded to the rate of the change. The faster the rate of change, the more signal you have. So here again, cranial nerves 9, cranial nerve 10, picking it up from the carotids, picking up from the aortic arch. More pressure, more mechanoreceptors. The baroreceptors are here at the bifurcation of the carotids. That's in the sleeper hold when somebody gets squeezed on those carotid baroreceptors and you pass out. It's in the walls of the carotid sinuses at the bifurcation, and the carotid sinus nerve goes to the glossopharyngeal, cranial nerve 9. There's a good step 1 question for you, to the medulla. Okay, so the location of those baroreceptors, that's when you squeeze it, makes people pass out. Press on your own. And it makes people pass out. They basically, like little bulbs or dilations that will sense the pressure. More blood pressure means more firing because they are mechanoreceptors, and a faster increase in blood pressure. A faster increase because it checks the rate too. So that's why it is, it says, you see here, the amount of stimulation you have, the amount of stimulation you have, no stimulation. Blood pressure high, big stimulation. More blood pressure, more reception of stretch of mechanoreceptors. Cranial nerve 9, cranial nerve 10. So the afferent means 2. Afferent, is a fancy Latin word for 2. Cranial nerve 9, to where? To the carotids or to the brain? So when we say afferents in the neural system, we always mean towards, to the central nervous system. And the aortics, the afferents of the vagus nerve. The vagus nerve is both an afferent and an efferent nerve. The afferent means towards what? The aorta or towards the central nervous system. In the neural system, when we say afferent, we mean to the central nervous system, to the medulla. And the medulla then slows the heart rate and dilate. Slow the rate and dilate. Slows the rate and dilate. Slows the rate and dilates when it senses a very high blood pressure. But orthostasis is when stimulation stops. Next one. It's a man with the fever and a murmur. And a murmur and a fever and a fever and a murmur and a murmur and a fever. And the lesions are painful and tender. What are they? What is the most accurate test? What are they? Ooh, ee, ah, ooh. Fever and a murmur, and a murmur and a fever, and a fever and a murmur and a murmur and a fever. Red and painful and tender. Osler. Osler's nodes are painful and raised and tender. And they are embolic phenomena. Let's look at them again. They are the embolic phenomena of endocarditis. It doesn't matter that they're rare. It matters that you just need to know that if you have culture-negative endocarditis, they help you to make the diagnosis, and they're shown them on step 1. There you go. Osler's nodes are embolic phenomena of endocarditis, flopping off vascular platelet plaques, platelet plaques with bacteria in them. Boom, getting caught in those blood vessels, and they're raised and painful. Janeways are flat and painless. Janeways are flat and painless. Oslers are raised and painful. Now, the most accurate test for endocarditis is blood cultures and an abnormal echo. Those 2 things are the 2 major criteria to diagnose endocarditis. Now, Vierdens group strep in your mouth. Vierdens group strep. Speciation, Malari, Meiteor, mutans, Salivarius, sanguis, Malari, Meiteor, mutans, Salivarius, sanguis, all Vierdens group. They all are treated with about the same thing. So Osler's nodes don't tell you which one you have. They're just a sign of the embolic phenomena of endocarditis. Next sound. So, what do you got? An infant. Failure to thrive. An infant not feeding. Short of breath. Oh, see, that's the key word. Continuous murmur. There's not too many continuous murmurs. Continuous means that it's through both systole and diastole. That's what continuous means. Systole and diastole. There's not too many things that are both systole and diastole. Okay, also sometimes called as a machinery murmur through systole. Always leaky. And that murmur is the murmur of a patent ductus arteriosus. Now, you will most likely never meet a human being with a patent ductus arteriosus because they are repaired or closed, either used non-steroidals to inhibit prostaglandins and close them in infancy, or surgical closure, but you'll almost never meet an adult with a patent ductus arteriosus. Okay, but this murmur, the most accurate test for all murmurs, echo. Catheterization can be the most accurate, not necessary, but echocardiography, transthoracic first, transesophageal better. Transthoracic first, transesophageal better, always. Transthoracic first, transesophageal better. Transthoracic first and transesophageal better. Close it! It's leaky. Shut that door. It's cold in here. Now, patent ductus arteriosus is a continuous murmur, and seriously ill children just don't eat. That's what happens when parents call up and they say, I'm so worried, my daughter, she's got like 104 fever, you know, she couldn't sleep, I'm like, oh, is she eating? Well, yeah. Well, is she walking around? Is she active? Is she playing? Oh, yeah, she's running around. Yeah. Well, don't worry about it. Because sick children declare themselves by not eating and not moving. Now, PDA, though, is a baby diagnosis. It's a baby diagnosis that's heard in the infraclavicular lesions, underneath the clavicles. And a thrill is a palpable murmur. That's a murmur that's so loud, so intense, it actually sends a vibration you can feel. It's so loud, so intense, it sends a vibration that you can feel. And if untreated, you get congestive failure and pulmonary hypertension. There's a patent ductus arteriosus. There's that connecting point. There's the connecting point. Now, this is a normal embryonic finding because remember, we don't want blood going to lungs in infants. I should say inside the uterus, excuse me. So we want to say that we don't want blood going to lungs when the fetus, when the baby is still inside the uterus, because you're not breathing. You don't even have snorkeling in there and all that amniotic fluid in the uterus. So we want it to bypass the uterus. We want it to bypass the lungs while in the uterus and go straight from the pulmonary artery into the aorta. Bypasses the lungs because the lungs are squished. Now, when you give birth, when you're born, the pressure inside the lungs goes down and the blood should start going into the lungs and the ductus arteriosus should close. There's nobody walking around with a patent ductus arteriosus because if it's not closed, what you'll do is you do an echo to find it there, to get indomethacin or other non-steroidals to close it up, because with prostaglandin inhibition should close it up. And if that won't work, if a non-steroidal won't work, then the answer is surgical closure of it's performed. And you take the little cutie baby, and you basically take that thing and clip it off, suture it off, close it off. Now, which of the shunts is most likely to be open in an adult? If I just said patent ductus arteriosus is not open in an adult. The one that's most likely to be open in an adult is the foramen ovale. That's the one most likely to be open in an adult. So the left to right shunt can eventually, because remember, when you're born, the left to right shunt, it goes left to right. Why does it go left to right? Because the pressure is greater where? The left or the right? The pressure is greater on the left. But what happens eventually is the right ventricle can become so big and so thick that the shunt starts to go from right to left. And what that is, why that means left to right, right to left, I can't understand it, skip it, I don't want to do this, I want to be an orthopedic surgeon. Why this is important is because left to right shunt, right to left shunt, Which one of those is more dangerous? Ooh. The right to left shunt is more dangerous because it's deoxygenated blood. The right to left is more dangerous because if you go right to left, if the shunt reverses and it's right to left, that's deoxygenated blood going into your left ventricle and you desaturate. Right to left is deoxygenated blood. That's cyanotic heart disease. So right to left is much worse. That's Eisenmenger's. When a left to right shunt eventually becomes a right to left shunt, and that's Eisenmenger's. What do you hear? What do you hear? What do you hear? What do you hear? Now, ooh, it's a friction rub. Friction rub, a pleural friction rub, and pericardial friction rubs. Those are the two kinds of friction rubs we have. They're leathery, velcro-y sounding signs of a pleural friction rub. It sounds like Velcro. Like those of you who have hair, take your hair and rub it together. I can't do that. Okay, it sounds like a leathery, scratchy sound, and the patient has pain, pain, pain. Patient has pain, pain, pain. Then they're breathing, breathing, breathing. Pleuritic pain, pain, pain. And the cause of friction rubs is infection. The infection often, sometimes uremia, sometimes lupus, but usually infections in there. And when you see a rub in the case, it's often an infection with the two parts of the pleura, with the visceral pleura and the parietal pleura, the visceral pleura, the parietal pleura, the visceral pleura, the parietal pleura get inflamed and start rubbing against each other. Pleural rub. Now, everything I just said about pleural rub, you actually can apply the same terms to the pericardial rub. The pleural and the pericardial rub largely has the same findings in terms of a Velcro, leathery sound rubbing against each other, just like the sound I showed you. And it's in timing with respiration. So that's one of the ways you can tell it's not a pericardial rub. Because if you said, hey, fishy, 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 you just said pleural pericardial rubs sound very similar. How am I supposed to tell it's not a pericardial rub? The answer is pericardial rub is going with the heart rate. But pleural rub is in timing with inspiration and expiration. That's how you'll tell the difference because of the timing. Stop breathing, it should go away. Because pathology, nasty. Nasty lungs. So this is the gooey. It has a certain, I don't know what. So it's sharp pain that gets worsened by respiration. That's what means pleuritic pain. Okay, and pleuritic pain gets decreased by splinting. Splinting means that you don't breathe in that side. For instance, if you have a pleural rub on one side, you end up leaning towards that side and you start breathing on the other side. And the problem is that not breathing on the side, not breathing on one side, leads to atelectasis. Splinting is like guarding. Guarding means don't touch me, don't touch me, don't move, don't move. It's like guarding. And what ends up happening is that you get pneumonia after the atelectasis. So the patient has decreased breathing on the side of the rub, and this leads to atelectasis pneumonia the same way it does when somebody has a rib fracture. Rib fractures do exactly the same thing. Our next slide, card 26. Remember, these slides that we're doing here in the set is in the same order as the cards in the box. So what you should be doing is read the card in the box, then watch the video. That will help you to get the maximum out of this. And you can carry them around with you and take notes. Pericardial knock. What a great sound. How poetic, a knock. What is it? No, I think it's a knock against the pericardium, isn't it? A pericardial knock is in the question. It means constrictive pericarditis. And the most accurate test for constrictive is actually not an echocardiogram, CT, MRI. MRI, CT is the most accurate. The pericardial knock is the sound as the ventricle fills, bang, it hits the pericardium. As the ventricle fills, bang, it's the pericardium. As the ventricle fills, bang, it's the pericardium. Ventricular filling and hits the pericardium with a knock, pericardial knock. So a third heart sound in diastole as it's filling. And because as it becomes full, it can't expand in diameter because it's a calcified fibrotic pericardium. And that calcified fibrotic pericardium, it hits with a knock and makes it so that it is an extra sound when it stops filling. Because it hits the pericardium. So now, as it starts, okay, and then what happens is massive drop in Y descent, because after the heart empties, and then it comes time to fill again, there's a precipitous drop in the pressure because it's the knock sound and then a precipitous drop in the pressure and that exaggerated Y descent. There's the step one question for you. What is characterized most on venogram, on venous pressures, on jugular venous pressure, pericardial knock? And the answer is an exaggerated Y descent after the heart empties. Drops. Now, constrictive pericarditis has to be from chronic inflammation. Here's the pathology question. Tuberculosis, fungus, chronicity, fibrosis, fibrinoid necrosis, tightening. And it tightens it up. The most accurate test of constrictive pericarditis is the anatomic tests like a CT and an MRI are the most accurate thing because you're seeing thickening and calcification to be able to detect the abnormal fibrosis and thickening. This is constrictive pericarditis on a drawing. This is it on a CT, and it calcifies, MRI, calcifies up there on the pericardium, and the only way to fix it is to remove it. There's no medical therapy really. We can use a diuretic, but a diuretic that's just symptomatic relief. If you're really all tightened up around your heart to the point where you can't breathe, if you're tightened up around your heart to the point where you can't breathe, you better remove that. That's like closing your penis in the zipper of your pants. I can't even believe I say things like that. It's disgusting. I hate myself. So the pulsus paradoxus, what is it? Now, we don't have a picture of a pulsus paradoxus because it's a blood pressure finding. A blood pressure finding because it's an exaggerated drop in blood pressure on inhalation. That's the definition. An exaggerated drop in blood pressure. Everybody's blood pressure will drop when you inhale, but it shouldn't drop more than 10 millimeters of mercury. But it does in a pulsus paradoxus. The most likely diagnosis with a pulsus paradoxus is pericardial tamponade. Pericardial tamponade in the pulsus, and the initial therapy is fluids because you want to fill up the heart so it can actually push open that effusion, that pericardial effusion, by pushing open the heart. Now, pulsus paradoxus is when you inhale, you have a drop in blood pressure more than 10 millimeters of mercury on inhalation. Now, everybody's blood pressure drops a little because when you inhale, what fills? The right side of the heart or the left side of the heart when you inhale? When you inhale, what fills? The right side of the heart or the left side of the heart? When you inhale, the right side fills first. And normally the heart just expands in external diameter. Normally the heart just expands in external diameter. But when you are encased in tamponading fluid, the heart can't just expand in external diameter because it's been encased. And that's why the blood pressure drops. So what's the paradox? Is that when you inhale, an intrathoracic pressure drops and you fill the right ventricle. The blood pressure here drops so much that the pulse can actually disappear. And that's the paradox. You inhale, systolic pressure goes under 90, pulse disappears. You exhale, the pulse came back. You inhale, and there's a big drop in blood pressure. Systolic less than 90. When the systolic goes less than 90, you don't have a radial pulse. You exhale, the blood pressure comes back and you feel the pulse. You inhale, and the right ventricle gets big. You inhale, the left ventricle gets small. The problem is you live off of your left ventricular output. You inhale, the right ventricle gets big and compresses the left ventricle to the point at which the pulse disappears. And then it comes back. So your pulse is gone, but you're still alive. That's so paradoxical. That's pulsus paradoxus. Right ventricle enlarges, left ventricle gets smaller, blood pressure drops, and the pulse goes away. Beautiful, isn't it? Now, a pulsus paradoxus, now it is true that you can have it in asthma, but the biggest point for you is that you understand that when the heart is compressed, it happens the most often. The others are less common here, and they don't need them. You don't need a pulsus paradoxus to diagnose asthma, where you can hear the wheezing. The bolus of fluids is to push the the heart open so you don't have hypotension. All hypotensions are treated with fluids. And this is the respiratory variation. Big complexes, small complexes, big complexes, small complexes, but it's exaggerated because the heart is flopping forward and backwards in the chest because it's in a bath of fluid. And then when the heart flops forward, the complexes get bigger. When the heart flops backwards, the complexes get smaller. When the heart flops forward, the complexes get bigger. The heart flops backwards, the complexes get smaller because the heart is physically distant from the anterior chest wall. The leads are here. If the heart flops away from it, the impulses go down. When the heart flops towards it, the impulses go up. Pulsus paradoxus, and this is called electrical alternans. That's a very important EKG finding because tamponade, if you have it and you don't put a needle in that chest to suck out the fluids, you die right away like that. Now, the earliest finding of tamponade is what? What's the earliest finding? Even before pulsus paradoxus, the earliest finding is right atrial and right ventricular diastolic collapse. That's the earliest finding of tamponade is right atrial and right ventricular diastolic collapse. Now, here we go. Pulsus parvus et tardus. You should use this for yourself like this. As a, gee, you're small and you're late. No, I'm not small and late. I'm parvus and tardus. Okay, that's what that means. Parvus and tardus. This is where we get the word parvovirus, the smallest virus there is, smallest DNA virus. Parvovirus because it's parvus, smaller. Tardus means late, like you're tardy. Okay, so that is basically small and late pulse. And the most likely diagnosis is aortic stenosis. The most accurate test for aortic stenosis, echo, cath, echocardiogram, cardiac catheterization. Cardiac catheterization, rarely necessary, and 99% of the time diagnosed off of echocardiography. Cath is the most accurate though. It literally means that the pulse is diminished and late because there's aortic stenosis in the way. So the pulse is blocked. That's a fancy word for blocked pulse in the carotids. Aortic stenosis blocks the ejection of blood, and the pulse is late and it's slow in the carotids. Da-da-da-dum. Calcified aortic valve blocks the carotid upstroke. As they say, BFD. Okay, and here it is. It blocks it. Blood's unable to flow up because it's stenotic. Pretty picture. So it's blocked, it's blocked, it's blocked, it's blocked. This gets slower and later and slower and later. That's it. That part is blocked. That's what's blocked. That's what's blocked. And it's a sign also of valve gradient. This is the pressure inside the left ventricle. This is the pressure in the aorta. That valve gradient is a sign of the severity of aortic stenosis. It's the sign of it being blocked. That's the block. It's suppressed because this is the pressure in the ventricle, but this is all that makes it to the aorta. This is the pressure in the ventricle, but this is the pressure in the aorta. It's blocked. This is a different representation of the same thing. The gradient. Ooh, this is a beautiful picture. Aortic stenosis, crescendo, decrescendo. Remember, isovolumetric contraction, isovolumetric relaxation. Ooh, there's a really good one. I like this one. Let's take a look. Fingernails. Bum 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 bum. It is whose pulse? It is Quinky Pulse! The Quinky Pulse. Don't you wish you were Quinky? I have a pulse named after me. It's like, okay, so Quinky's pulse is a sign of aortic regurgitation, aortic insufficiency. When you see it in the question, your answer is say, get an echocardiogram to look for aortic regurgitation, and this person automatically needs that valve tightened up, repaired and replaced, repaired and replaced. Echo first, transthoracic first, transesophageal best. Beautiful picture of Quinky pulse for aortic regurgitation, aortic insufficiency. It's a pulsation in the nail beds, and when it's present, it just means that it's a high bounding pulse. In the carotids, it'd be called the water hammer pulse. In your head, it'd be called Demusset sign, head bobbing, and I got regurg now, da-da. In the fingernails. So when a Quinky pulse is described in the fingernail beds, you should be getting an echocardiogram and evaluating for surgical repair or surgical replacement. Super. Next sound. Hey, stop. What's that sound? So what is it? What is it? A man comes to the erectile dysfunction. Sorry, emergency department. Comes to the emergency department with shortness of breath, jugular venous distension, edema, Ralls, and he's got suddenly worse overnight while sleeping. Okay, and he sits up and he feels better. That's called orthopnea, when you sit up and you feel better. And this additional sound is heard. And what is the sound that you're most likely, and what causes it? The most common cause of that sound. This is the cardiology section, so always say echocardiogram, echocath. The S3 gallop. Well, we did that before, yes, but it's different based on the case. The S3 gallop is the additional sound of rapid ventricular filling. The mitral valve opens. The blood rushes into the ventricle, and it hits with a splash. There's shortness of breath because you're overloaded. Orthopnea, because when you lie flat, your lungs get filled with fluid. And paroxysmal nocturnal dyspnea is because at night, again, you're lying around asleep, and you wake up feeling like you're gasping for air. The S3 gallop is rapid ventricular filling, sign of congestive heart failure. In a symptomatic person, S3 gallop always means that you need immediate therapy with a diuretic. It's very serious. No one is allowed to go home and walk around with an S3 gallop. It is very serious, very dangerous, and it's always going to be hospitalized when it's associated with congestive failure, because no one should be allowed to have that large amount of fluid overload, because the S3 gallop is filled with rapid ventricular filling from massive fluid overload. The one in the healthy young person, it will never be confused, because those people are asymptomatic. The healthy young person will not be short of breath. Now, the most accurate test, not of valve disease, but of ejection fraction, is the nuclear ventriculogram. The most accurate test of ejection fraction. Now, we'll be having, okay, you can see those things by going by test. when we see the diagnostic test flashcard series. Here we're doing physical findings. The next one will be the diagnostic test one, and there'll be a most likely diagnosis one and pharmacology, because these are the 4 basic questions in our tests. What's the most likely diagnosis? What is the best initial test, the most accurate test? Which physical finding is most likely to be found in this patient? And what's the therapy? This test, the MUGA or nuclear ventriculogram, is the most accurate method of assessing ejection fraction. Even more accurate than an echo. Now, what do you do? Echo. What is the most accurate, even more than echo, for ejection fraction? The answer is the MUGA scan or nuclear ventriculogram. Look it up. Write it down and look it up. All right? Yeah, man, look it up. Takes a long time to get to be me. See you in the next section.